Hi guys, this is Alicia with Good Morning Sunshine. So today we had 4 lectures. I'm going to go over 3 with you because I've already done one of them. And then we also had lab today on clinical pathology, so reading blood work and looking at blood slides. So that was fun. It actually hurt my brain a lot because we had to put all the information together of what we learned from clinical pathology into this lab. But starting off with, I had pharmacology, so I'm going to start off with that. Luckily, most of this information I knew already just by working, so it was nice because we're going over anti-inflammatory agents, so non-steroidal anti-inflammatory drugs, also known as NSAIDs. So basically, this is our diagram here. As you can see, we have inflammation up here. So under the influence of an inflammatory stimulus, the membrane phospholipids are broken down by phospholipase A2, also known as PLA2, into arachidonic acid, which is further broken down into prostaglandins, also known as PGs, and leukotrienes, also known as LTs, resulting in the amplification of the inflammatory response. So as you can see, we get inflammation, triggers a response. So then the phospholipase here is what promotes the arachidonic acid, and then the arachidonic acid further breaks down to the leukotrienes, like I said, and the prostaglandins H2 here. However, if you are using an anti-inflammatory drug, so an NSAID, here, so the NSAIDs are what block the COX-1 and COX-2, also known as the cyclooxygenase 1 and 2, or they block both, so depending on what NSAID you are using. So you're reducing or eliminating the production of the prostaglandin H2 here. So with this decreased inflammation, they have little to no effect on the other pathway, though, where the arachidonic acid is yielding the leukotrienes. So basically, the inflammations only block the production of the prostaglandins. But if you use a steroid, it blocks both of these pathways. But for NSAIDs, it blocks the production of the prostaglandins. So NSAIDs do work for our benefit. Steroids, of course, work better. However, they have many adverse effects. NSAIDs do as well, but not as bad as steroids. So NSAIDs, mechanism of action simplified. So she showed us this picture here, what I thought was funny. So everything I just explained. So you have the arachidonic acid, and then you have the NSAID, but it only blocks the prostaglandins, not the leukotrienes. So then she showed us major effects. So these, I don't know the true names of these, but she gave us the PGI2. So that has to do with decreasing clot formation. This is everything to do with the prostaglandins. And then TXA2 causes platelet aggregation. And then PGE2 is an inflammatory mediator, so it's an upregulator when we have an inflammatory stimulus. And then we have PGF2 alpha, which causes vasoconstriction, smooth muscle contraction in the uterus. So we say this is our reproductive prostaglandin. So going over cyclooxygenase 1 and 2, 1 constitutively is continuously basically expressed. So we are basically sitting here making this. It's produced for normal health, homing functions, but cyclooxygenase 2 is induced by inflammation. It produces prostaglandins, but we're not sitting here continuously making the cyclooxygenase 2. So we see, I'm going to show you this picture. So we see COX-1, it yields prostaglandins, and then it yields the cytoprotective. It's cytoprotective to the GI tract, so decreased acid and increased mucus. So we see COX-1 as the angel here. Whereas COX-2 is induced by inflammation, it makes prostaglandins, and it yields pro-inflammatory effects like heat, pain, swelling, and fever. So this is the devil side. So the cyclooxygenases, the theory behind COX-2 specific inhibitors, aka COX-1 sparing. So we in this theory, we believe if we only block the COX-2, so that's the bad part, then these things will happen, such as block the bad, you would leave the good effects of prostaglandins. So there's no adverse effects, but only if it were that easy, right? So it's not that simple. There's a lot of overlap. The COX-2 is constantly expressed in the kidney, especially for the dogs and horses. COX-2 is needed for mucosal healing. So if you were to block just COX-2 and you have a GI ulcer, it will be unable to help this. And then specificity of most drugs is overcome at high doses. So COX selectivity, it varies by the drug and varies by the species. So carprofen is not selective in people, but it appears to be selective in dogs. Another drug, the opposite may be true. So we don't want to extrapolate between species. So clinical uses, why we use NSAIDs. So for fever or fever caused by infection, also, but not all fevers need treatment. So fevers can kill bacteria, etc. So some fever good, but a lot of fever is bad. That's when we should use an NSAID. However, people or vets also usually prescribe NSAIDs even if we have a mild fever, which is not really necessary. For anesthetic reasons, it's very effective with pain associated with inflammation. So it's labeled for chronic osteoarthritis, so soft tissue injuries. Also, NSAIDs are good for post-operative pain. So usually at my work, we would prescribe these after they had the animals had an operation. So it's pain independent of inflammation, so it's less effective, which you already know it's not as good as steroids, but there are reasons behind this. So the clinical use is continued. We have endotoxemia and sepsis. It's a systematic inflammatory response. So prostaglandins are responsible for many of these clinical signs. An anticoagulant, so platelet activity. We want a drug that blocks COX-1 here. So low-dose aspirin is best understood. All NSAIDs affect coagulation. The clinical significance varies with species. Small animals affected more than large. And COX-2 and thrombosis. So NSAIDs are not appropriate for certain things, so you would choose a steroid instead or another drug. These things being immune-mediated diseases, such as immune-mediated hemolytic anemia, and then autoimmune diseases, and also allergic diseases, and inflammatory respiratory diseases such as asthma or chronic bronchitis. So you would need steroids or other drugs for these. So the NSAID pharmacokinetics is they tend to stay in the plasma until there is inflammation. They are metabolized by the liver. So in general, they're well absorbed orally. They're high bioavailability, so having to do with active transport. They have a small volume of distribution. They have high protein binding. So therefore, hepatic metabolism predominates. Capacity limited, so nonlinear pharmacokinetics at higher doses. So species differences, neonates we have to be careful of when we prescribe these, or any drugs in general, actually. And then dosing in one species is unlikely correct for another. So like Deroxicab, the half-life. So it's 3 hours at 2 to 3 milligrams per kilogram. But it can be, if a dog were to ingest like the whole bottle of this, it would be 19 hours at 20 milligrams per kilogram. Also, carprofen half-lives for dogs is 11 hours, whereas for cats it's 20 hours, and for horses it's 21. So it's different in different species. So choosing an NSAID. So there's many different kinds of NSAIDs, a few basic anti-inflammatory activities. An animal that does not respond to one NSAID may respond better to another NSAID, but however, they have the same properties. Choices are related to the pattern of use, experience, and tradition. So horses, their NSAIDs are flunioxazine for visceral pain such as colic. There's also phenobutazone for musculoskeletal pain, so for lameness. But studies show very little difference between those two NSAIDs. They're basically the same thing, but veterinarians choose one over the other. And then client education. Human NSAIDs will make your pet die a horrible death. I will put this into your brain. Do not give human NSAIDs to your pet, please. So such as Tylenol is an atypical NSAID it will kill your cat very quickly. So do not give your cat Tylenol. Or if it ingests Tylenol, you better be rushing it to the hospital. Dogs, it's okay up to a certain point. However, this is at low doses. You can still kill your dog. But for horses, it's okay. For ibuprofen, this leads to bloody vomit. This will definitely kill your animals. It will kill your dog. It will kill your cat. So please don't do it. Please don't. NSAIDs by species, cats are susceptible to NSAID adverse effects. So they're more affected or have more adverse effects than canines do, but canines still have adverse effects. Horses also have very bad adverse effects to these. So canines, NSAIDs are carprofen, meloxicam, thyroxib, robencoxib, and diracoxib. Cats can use meloxicam, and they can also use the robencoxib. And again, like I said, horses are susceptible to adverse effects as well. So flunexin, maglutamine is common. It is to block the COX-1 and 2. Actually, all of these block COX-1 and COX-2, all except for the thyrocoxib in horses. The phenylbutazone is commonly used. There's also ketoprofen and diclofenac, which is used topically. For food animals, such as cattle, they use flunexin, maglutamine intravenously. Pyrexia associated with BRDC and endotoxemia. So the control of inflammation, this is to control inflammation and endotoxemia. And then the flunexin maglutamine can be transdermal. This was recent. It was actually the first drug labeled for analgesia in a food animal species in the United States. And then we have ketoprofen, which is pyrexia with BRDC, and it can be combined with an antibiotic. And then getting into more food animals, so there's extra label drug use like meloxicam, which is used frequently for pain. We have the phenylbutazone, but it's not safe really in any species because it likes to go to the milk, and it goes to the milk supply, which is not good for humans either. So it's prohibited in adult dairy cattle, so 20 months of age or older. It is great for hard to treat animals. Usually these are our bulls, our mean bulls, so it's our breeding bulls, and it can be put into their feed that way. This drug has a very long half-life. It's 55 hours. In horses, it has extended withdrawal times. As long as 90 days. Animals such as swine, there's no pain meds approved for swine in the United States, which is very sad. They use flexinin maglutamine, intermuscular only though. Pyrexia is associated with swine respiratory disease. So now getting into the adverse effects of NSAIDs. There are numerous, and some are very dangerous. If you know what the adverse effects are, you can monitor for them and even prevent and minimize the effects. So we as veterinarians need to know the adverse effects and when we see them. So GI ulcers for NSAIDs, I knew this because working GI upset was one of them, and you cannot put steroids with NSAIDs. So NSAIDs should not be used if the animal already has a GI issue or disease. The GI tract part depends on the species. So in dogs and cats, it's usually in the stomach and the small intestine, whereas horses, it's in the stomach and colon, specifically the right dorsal colon, and for ruminants, it's the abomasum. So PGE2 effects, so it's not just with oral administrations, with the injections too. So PGE2 is necessary for healing with pre-existing damage. So the COX-2 inhibitors can delay healing or cause progression of this disease. So safer, but not entirely safe. So she gave us a few examples of the adverse effects. This is a duodenum. This is a 10-year-old Rottweiler, which had osteoarthritis. It was on diracoxib for a year, which is a COX-2 inhibitor. And as you can see, there's a big hole in the duodenum. Big hole. And then the next picture is a horse that was taking phenylbutazone. So most GI ulceration in horses So there's a big hole right there. This is the pylorus of the stomach, and there's a giant hole caused by taking phenylbutazone. And then we have phyrocoxib. These are erosions and bleeding ulcers in the stomach. And then we have phenylbutazone again and phyroxib together. So this is inside the colon of a horse. So do not combine NSAIDs either. This increases adverse effects. So the red areas here are ulcerations. Some more adverse effects. We have nephrotoxicity, which is the inhibition of PGE and PGI2. It causes vasoconstriction, decreased renal, and possible toxicity. Effects are greatly exuberated and dehydrated patients. So it's already compromised renal blood flow. PGE2 constitutively expressed in the kidney, like I said earlier, and COX-2 inhibitors probably not safer here. Lesions are characterized by medullary crest or renal papillary necrosis. Normally receive less blood flow and they're more vulnerable to insult. Areas that concentrate urine, inability to concentrate urine. So here is an acute renal failure on the left here in the blue, and then we have the chronic NSAID toxicity in the horse and its kidneys on the right here. Hemorrhage, trauma, or surgery. So effects on the platelets. Drugs that inhibit COX-1 activity. You'd have thromboxane A2. Aspirin irreversibly binds COX-1 in the platelet, so effects last for the life of the platelet, so usually 7 to 10 days. Most NSAIDs can induce prolonged bleeding, so less of an issue in large animals, however. So selective COX-2 inhibitors reduces PGI2, so prostacyclin. Little or no inhibition of the prothrombotic thromboxane, so COX-1, and then veterinary significance is unknown. Hepatotoxicity. All NSAIDs are fairly low incidence, mainly dogs. The toxic principal mechanism is not clear. Idiopathic, not reproducible, so carprofen. Labrador retrievers. So they have anorexia, vomiting, icterus. They have hepatomegaly, which means the large liver, and increased bilirubin. So ALT, ALP, and AST is also increased. These are our liver enzymes. So IMH, so that's immune-mediated, what did I say earlier? It's gonna come back to me. Something anemia, hemolytic anemia, and then immune-mediated thrombocytopenia. So up to 12% of drug-induced IMHA and IMTP cases in humans attributed to NSAIDs. So it's rare in animal species, but there's one published case report in a dog with carprofen, second exposure 48 hours after initiating therapy. We also have blood dyscrasias, so phenylbutazone, pancytopenic bone marrow failure, so it's non-regenerative anemia and thrombocytopenia. People and dogs, this is bad, especially bad in cats. They might actually explode. And it's not used in either species anymore. So we do not definitely want to use phenylbutazone in dogs or cats at all. There's also injection site reactions to these. There's heat, pain, and swelling, abscess formation, tissue necrosis, and clostridial myositis. For phenylbutazone, there's perivascular administration, so severe tissue necrosis. And if the injection is made in the left side of the neck, the vagosympathetic trunk, the left recurrent laryngeal nerve, and the esophagus may be damaged. So here's a picture of that. And then we have clostridial myositis, so IM flunixin megulamine. So 2 weeks later, turn to this. And then 6 weeks later and $10,000 later, they were able to fix it, but a lot of money and a lot of money doesn't matter, but look at this horse. Look how sad that is. So minimizing adverse effects, so injection site reactions, so prevention, both the injectable formulations of phenylbutazone and flunixin can be given orally. Bioavailability similar to commercially available preparations. Taste terrible and can be irritating, so you'd mix with corn syrup and rinse their mouth with water. So dose appropriately, lowest effective dose at the longest effective dosing interval for these NSAIDs. You want to be very careful. You don't want the adverse effects. Also, right drug and formulation. Choose COX-2 selective. Firocoxibib in horses is safer versus in dogs. Dedicated dosing syringe for cats and small dogs. So they're not getting overdosed, especially by the parents. So GI protection. There's this thing known as misoprostol, which coats the stomach. I don't know. It might prevent ulcers, they say, with GIs or with NSAID stuff, but it's not recommended to use this. Also, protein pump inhibitors such as omeprazole, alter microbiome may hurt. And then we want to avoid co-administration of other nephrotoxic drugs and avoid co-administration of NSAIDs together. This includes co-administration of non-selective and COX-2 selective drugs, and also used with extreme caution in animals with underlying diseases. So subclinical renal disease, subclinical GI disease, or subclinical liver disease. So risk is increased in animals when they are anorexic, when they are dehydrated. So you want the client to have some education, so let them know the warning signs. Also make a client information sheet about the drug, and also make them sign it so they know what they're giving their animal. Also monitoring, so prolonged dosing, high dosing, blood work, pre and post treatment, so PCV and red blood cell count, and total protein for albumin, bumin and creatinine, and liver enzymes for dogs and cats. So that was a long lecture for pharmacokinetics. And then we had virology for 2 lectures. So the definition, so virology, epidemiology is diseases in populations developed before recognition of causative agents. So there's 3 independent terms define increasing size of populations. So we have enzootic, also known as endemic, but that's the human name. He wants us to use the veterinary name. So enzootic, it means multiple continuous transmissions, disease presence in a defined population, region, and time. Also, we have epidemic. Also, that's a human word. He wants us to use episodic, I don't know. Peaks in incidence exceeding the endemic baseline. Nature and degree of expected damage defines whether it's called episodic, high damage or not, and low damage. So we have pandemic, but we call it panzootic, which means worldwide epidemics. And then we have rate, incidence, and prevalence. I've talked to you about incidence and prevalence before, so we're just going to quickly go over that. So rate is diseases in population. So rate equals the number of cases divided by population or per population. So different diseases equals different rates. Incidence has to do with new cases again, or attack rate. It's the number of cases over a number of subjects over a period of time. So then we have acute short duration diseases. The denominator is population in a time frame, thus person years or subject weeks. And then we have prevalence, which is the insidious onset with unknown initial date. So we don't know what's new cases or what's old cases. So these have to do with chronic long duration diseases. So no time parameters, only number of cases and a defined number of subject. So parameters defining incidence, there's 3 in acute diseases. So the 3 being are the proportion of the population which is susceptible, the proportion of the infected and susceptible individuals, and the proportion of the diseased infected individuals. So in viral diseases, we have a case divided by infection ratio, which equals the proportion of infections resulting in clinical disease. Then we also have the case divided by the fatality ratio, which equals the proportion of infections resulting in lethal disease. Varied characteristics for each disease. And then we have the new biotypes, which are changed characteristics. So other viral epidemiological terms are data. So that's the data. So acquisition is difficult, incomplete, and inaccurate. So computation is easier. We have surveillance, which is the continuous reporting reportable diseases. So you still want to keep up with continuously reporting. We have serological survey, which is antibody clinical disease are silent. Subclinical infections, not informative on current infections though, however. We have prospective studies, we don't do this often, and then we have retrospective studies, which are most cost effective, only needed limited numbers of subjects. We have courses of virus infection in a single animal. So we have the incubation period, which varies from disease to disease. So that's the incubation period is the moment of infection to the onset of clinical signs. So is it short, long, or variable? Then we also have the generation time, which is from the moment of infection to the first day, for the first day virus sheds. So it's mostly shorter than the incubation period in its influence in spreading the disease. And then we have the period of infectivity, which is important. So this is from the first day to the last day of the virus shedding. It may or may not be longer than the clinical signs. That is bad if we do not know when the animal is sick yet, when we don't know the animal is sick yet, and they are already shedding the virus. It's a great influence in spreading disease. Then we have chronic viral diseases. Distinctive between these time periods is difficult. There's little correlation among disease, generation time, and infectivity. And then we have modes of transmission by virus. So we have horizontal transmission, we have vertical transmission, zoonotic transmission, vector-borne transmission, iatrogenic, and nosocomial. We're going to start with horizontal transmission. Horizontal is with or without a vector between the same or different host species. So you can either do this by direct contact, so licking, rubbing, biting, sexual contact, etc., suitable for the transmission of enveloped viruses. So enveloped viruses do not survive an environment for long periods of time. But then we have indirect contact, which is fomites. This would be like a doorknob. So the virus surviving on surfaces, and then we touch that surface. Such as eating, bedding, vehicles, surgical instruments, and needles. These are for non-enveloped viruses. They can survive in the environment for longer periods of time, and they usually use this route of transmission. So the common vehicle would be water and food, so like water bowls that you put your thing in, so the virus is just sitting there waiting to be drinking up or eaten. And then we have airborne, such as droplets and aerosols. And then vertical transmission, this is from like your mom to baby. So vertical is the movement of virus from parents to their offspring during gestation via placenta, perinatally, colostrum, or with milk. And then we have germline transmission, which is the virus integrated into the genome of the ovum and the transcription and replication in the offspring. They pass from generation to generation. And then we have arthropod vector-borne arbovirus transmission. So we need to know the difference between the two. There's the biological vector, which is the virus replicates in the vector, they multiply in the vector, and they have efficient transmission. However, a mechanical carrier vector, there's no virus replication in vectors, and it's not efficient for transmission. And then we have zoonotic transmission. So transmission from animal to human or human to animal. So definition, viral diseases transmitted under natural conditions from vertebrate animals to humans. So again, this would be like a dog getting bit by, I just forgot what this animal is called. But bear with me, getting bitten, and then they are giving us rabies. So that's no good. And then the majority of human infectious diseases are zoonotic. So among the 1,407 recognized human pathogens, 816 of them are zoonotic. So they can pass it to us. That's more than 50%. That's 58%. And then of the 335 emerging human infection diseases since 1940, 202 of them are zoonotic. So that's 60% of them. And then other modes of transmission when under veterinary care, so our own care. That's the iatrogenic, which is patient-to-patient transmission under veterinary care during the interaction between the vets and the animals. So example, this would be using like the same needle between patients. And then we have nosocomial, which is the transmission that occurs while the animals are in the hospital or the clinic under the care of veterinarians. Both of these are preventable. Patterns of virus infections, you have acute infection, which is the rapid production of infectious viruses, the rapid resolution and elimination of the infection, so virus clearance by the host. And then acute infections do not always produce disease. And then we have persistent infection. So after acute infection, the virus still lingers around. Infection not cleared efficiently. Its virus particles are produced for a long period of time, either continuously or intermittently for months or even years. We have chronic infection, which is persistent infections that are eventually cleared. However, then we have latent infection with persistent infections that last the life of the host. Latent infections, there's latency. So that means viral genomes integrated into cellular genomes, not expressed, not infectious progeny. These are viruses that lay dormant within the animal or not expressed but are there. Then we have recrudescence, which is the activation of latency due to various reasons. So immunosuppressants, stress, etc. So new infectious virus progeny causing disease due to flare-up and new immune response. So example, so an animal gets stressed upon the transportation. So like a cow getting transported across the country, the virus would then flare up. So we want to quarantine these animals if you know they've been under a lot of stress. Other types of infections, we have productive, resulting in infectious progeny. We have abortive, which replication is initiated but not completed, so limited gene expression, so no infectious progeny. Then we have restrictive, so permissivity is transient for individual cells, or proportional, so cell population, and few virins are released. Then we have transforming infections. So DNA virus or retroviruses can integrate into the genome and cause cancer. We have infected cells that display altered growth properties and proliferate faster. We have integration of virus genome into host cells in some infection and causing cancer in animals. Patterns of infection and virus shedding. We have shedding, which is the last phase of viral pathogenesis. It's mandatory for virus to survive in the host. We have shedding through body openings and surfaces. We have local infections, so local shedding. We have systemic infections, so various shedding routes. And amount and timing of shedding defines outcome of the infection. And then routes of virus shedding, we have the skin. But this only happens when the skin is damaged, so it usually doesn't shed viruses. So it's not a major route. It has to have contact, abrasions, and wounds. And then respiratory secretions, such as coughing. This is very important shedding mechanism. So numerous diseases, local or systemic. Shedding occur before, during, or after clinical signs. And then saliva is like biting, so the salivary gland or oral cavity. This has to do with rabies and FIV. Feces, this is a high amount of viruses in the feces, so GI tract viruses, and many also without intestinal signs, such as polio. And then congenital, we have genital secretions, so sexual activity, semen, mucus. This is not a very used route. We have urine, the rinopest, foot and mouth disease, canine hepatitis, and kidneys. We have the hantaviruses, so mice to humans. The milk, this is not an important route either. We have the mammary gland replication, the Capran arthritis, and the encephalitis. There can be no shedding as well, so some viruses do not shed actually. This would be the encephalitis, so CNS, and the retroviruses and the germline. Then we have host range and restriction of virus transmission. Host range, some have broad or specific host range. Receptors on animals and tissues and cells susceptible for a wide range of infections or restricted infections. We have susceptibility, so the ability to become affected, but susceptibility does not equal permissivity. So permissivity is the ability to replicate and produce progeny viruses. Host factors in determining the outcomes of virus infection. These are age, sex, reproductive status of populations, immune status of populations, nutritional status of populations, genetics of populations, and outcomes of infections such as subclinical, mild, moderate, or lethal. So that was our first one of virology. And then our second lecture, let me pull up here. So we got into the virus replication cycle in host cells. So first step, we have attachment. So the attachment being the virus recognizes the target cell, so the attachment binding of the virus attachment proteins, so the VAPs on the surface of the virin to the receptors that is on the target cell. So they have to physically complement each other in order to bind. Our VAPs, so again, those are virus attachment proteins. We have non-envelope, which are part of the capsid or a protein extended from the capsid. And then we have the enveloped virus, so the spike or the peptide glycoproteins on the envelope. This is what I talked about in Virology 1, I think, yesterday. And then we have virus attachment proteins, so our VAPs. So an example of this, we don't have to memorize, but here are some. I'll just show you the table. I'm not going to go over the table with you, though. And then next step, we have recognition of the target cell. So receptors such as proteins, carbohydrates, or glycoproteins or glycolipids on the cell surface. Receptors on host cells determine the host range and tissue tropism. So virus receptors are these, which again, I'm not going to go over with you. And then thirdly, we have penetration. So it's energy dependent, it's rapid. We have translocation, so the non-enveloped virins just slip through. We have endocytosis, where the enveloped enveloped viruses get coated. And then we have fusion. We have some enveloped, so the viral membrane can fuse with the cell membrane. Thus, it gets integrated. So here's this. So this has to do with fusion, what I talked about. So some enveloped viruses get through this way. So the viral protein membrane can fuse with the cell membrane and then gets inside that way. And then we have endocytosis, where it gets gulfed up, kind of like phagocytosis. It gets coated, and that's how it gets inside. And then the lysosome goes to it there. And then we have uncoating. So once they're inside, they have to get uncoated. So the nuclear capsid is disintegrated, and the genome is freed in the cytoplasm, and the proteins disintegrate into the cytoplasm. So following uncoating, synthesis of viral proteins by cellular metabolism. And then we have translation. So the virus hijacks the host in order to replicate itself. So all of its machinery, the virus takes over in order so it can replicate its own cell. Then we have post-translational modifications to become mature proteins. So we have phosphorylation, so nucleic acid binding. We have fatty acid acylation, which is membrane insertion, and then we have glycosylation, and then we have proteolytic cleavage. And then we go to macromolecular synthesis, which is the transcription, the translation, the post-translational modification, and the viral genome replication. So in DNA viruses, they replicate in the nucleus except for the pox virus, so they replicate in the cytoplasm. But most use host cells, so DNA-dependent RNA polymerase II and other enzymes to describe the viral mRNA. The exception being, again, the pox viruses, and because they encode all enzymes in its genome. And then for the RNA viruses, they replicate in the cytoplasm. They must encode or carry necessary enzymes for transcription and replication in their genomes. The exception here being the orthomyxoviruses and the coronaviruses and the retroviruses. So then the next step, we have assembly. So the virus needs to assemble into mature virions. So the matrix protein facilitates this assembly. Then we have maturation, which the viral protein replaces the regular cell proteins. So here's pictures of these. And then we have the release, where the virus stills the cell membrane, but the protein on the cell membrane now has viral proteins. The viruses don't kill the cell, thus this meaning chronic infection. So here's the overall cycle. So we have the attachment here, we have the penetration, we have the uncoating, which leads to, which leads to transcription, translation, and replication, which goes to assembly, where it matures, and then it's finally released out. And then we have virus and host cell interactions, so the cytopathic effect, so CPE. CPE is changes in host cells from viral invasion. So the replicative cycle exclusively with living cells, so diseases in vivo and CPE in vitro. The CPE, so there's morphological changes of the infected cells such as rounding, lysis, detachment, inclusion bodies. So the cause of CPE formation is the direct pathological injury of the affected cells or due to side effect. And then sites of replication, DNA viruses in nucleus, and then RNA viruses in the cytoplasm, like I said. And then the effects of viruses on cell metabolism, like I said, it basically hijacks the machinery of the use for itself. These viruses do. So the cells themselves have inhibition of cellular transcription mechanisms, so inhibition of transcription of cellular mRNA by cellular polymerase II enzyme. They have the inhibition of RNA processing pathways, so the virus inhibits maturation of cellular mRNA and converts cellular pathway for virus's own use, such as capping, splicing, and polyadenylation. And then we have the inhibition of cellular translation, which is the inhibits cellular mRNA translation, as viral mRNAs are translated essentially the same as cellular mRNAs. And then lastly, we have the inhibition of the host cell DNA synthesis. So viruses inhibit host cell DNA synthesis to provide nucleic acid precursors for viral genome synthesis and to redirect host cell enzymes for viral DNA synthesis. So what effects do viruses have on cell structure? So the membrane fusion of neighboring cells, leading to the formation of syncytia, a characteristic CPE for several envelope viruses. Also the changing the permeability of the cell plasma membrane, so leading to increased influx of various ions, so toxins causing cell lysis. We have the disruption of cytoskeletal fiber systems, so microfilaments and microtubules causing rounding of cells, a frequent type of CPE. And then we have cytoskeletal components incorporated into affected cell structures, either in the cytoplasm or in the cytoplasm and nucleus as inclusion bodies. So the direction of the cytoskeleton system by the herpes virus is seen here. So the cells shrink, and you can see that here. And then how do the virus enter the host? Well, they enter through the respiratory tract, the GI tract, the conjunctiva, the genitourinary tract, and the skin and epidermis. So starting with the skin, this is the largest organ of the body. However, it's not the major site of entry, like I said. So the virus cannot replicate on the skin. They can only get in when the skin is damaged. Respiratory tract is important. So barriers, they have the mucus, mucociliary movement, neutrophils, and macrophages. So IgA, cell-mediated immune response, so in droplet size, air currents, humidity, and temperature. So many viruses, these include the coronaviruses, the endoviruses, the herpes viruses, the calicate viruses, the orthomycosis viruses, and many more. And then we have the gastrointestinal tract, which is important, but viruses have to be able to withstand the harsh conditions in the stomach. So what's unique about these are all the non-envelope viruses that go through this way. And then we have the genitourinary tract, which is not important in vet med really. And then we have the conjunctiva, which is not a major route either. And then we have virus spread, which if only infecting skin, body surface, cell-to-cell spread, local infection. And then we have systemic spread, which is distant tissues and organs. And then we have hematogenous spread, so viremia, which means virus in circulating blood. This is how they get around. This is important for them. So the vascular system is a major pathway. Systemic spread, they have entry site limited replication. They have primary viremia, which is a spread to distant organs, so major replication sites. They have secondary viremia, which is major clinical signs, and high viremia equals high virulence. Then we have lymphatic spread. So lymphatic spread is less important than viremia. Its primary replication is epithelial cells, the vascular system, and the spread is to the lymphatic vessels to other tissues. And then we have neural spread, so factors influence the spread via the CNS. So primary replication site, viremia, titer and length, and duration of nerve tissue exposure. The transport speed is about 2 to 16 millimeters per day along the nerve axons. This is like rabies, polioviruses, herpes viruses, and arboviruses. So different pathways may spread the same virus to the same target organ. And that was it. That's lots of stuff. And then we had lab. We also had to watch a video on another lecture as well. So just lots of stuff to know. We have 34 lectures, I guess, going into this exam. So that's 68 questions. But so much stuff to know. My brain just hurts. So that I have to learn more about 12 lectures a day. So 12 hours of lecture. That's a lot. But yeah. We'll get through it. Thank you guys for listening. I know a lot of information was just thrown at you. But yeah, that was only 3 lectures. 3. And those are all going to be on the exam on Monday. So that was the rest of our lectures. I just have an integrated session tomorrow. So, but thank you guys for watching, and I will talk to you guys tomorrow.